but also postprandial plasma glucose. And studies have shown that in trying to get patients to achieve A1C target, it is not only fasting plasma glucose that we should be concerned about, but also postprandial plasma glucose. Okay? So we have to target both fasting and postprandial glucose to achieve A1C target. All right. And the studies have also shown that on patients on basal insulin alone, okay, about 70% of patients on basal insulin alone fail to achieve A1C target. So which means that only 3 out of 10 will probably achieve target. The other 7 out of 10 patients will not achieve A1C target. And one of the reasons is that, as you can see from the contributions of postprandial and fasting to the A1C, you can see that the postprandial actually contributes higher to the A1C compared to the fasting. Okay? Initially, and when the A1C is high, more than 8%, fasting is contribute 41%. Okay? But the A1C is when you want the A1C to be at target, around 6.57%, then the contribution for fasting is only about 30%. And the other 2/3 comes from postprandial. So which means that even though I'm sure you hope the dogma is treat the fasting first, okay? It is only when the A1C is high, but once the A1C is coming closer to your target value, maybe 7.58, and you want it to be less than 7, or more than 6, less than 6.5, then we should be focusing on the postprandial to achieve our target A1C. Okay? So essentially, insulin is either prandial or basal. Okay? So basal insulin I've talked about, okay? And to act on the postprandial, you have to be the basal or the prandial insulin or the rapid-acting insulin. Okay? And of course, you have a mixture of those called premixed insulin, and now we have a new option, which is a co-formulation insulin. So I'll be discussing what is the difference between a premixed insulin and a co-formulated insulin. Okay? And this is the so-called the profile of a premixed insulin. Okay? You have a physiological profile where insulin, in response to meal, this is a rapid rise in the insulin levels. Okay? And sometimes to do that, to achieve that, we also need some level of basal insulin. And to achieve that, we tend to go for a basal bolus. Okay? For every meal, we have to give a prandial insulin, followed by a basal insulin either once daily. Yeah? But of course, the burden will be multiple injections, okay, and complex titration schedule. The premixed insulin, what the main concern is that the premixed insulin contains soluble insulin and NPH insulin. Okay? And the problem is that the NPH insulin can interfere with the soluble insulin and prolong the action a little bit and cause the so-called shoulder effect. Okay? Where there is and the side effect of the shoulder effect is that you have a late postprandial hypoglycemia. Okay? So this is because the NPH insulin interferes with the short-acting insulin. Okay? Now, the co-formulated insulin is basically insulin which contains the aspart insulin and the degludec insulin, long-acting insulin, and this coexists in the formulation and it works independently. Yeah? The degludec insulin does not interfere with the aspart insulin, so that aspart can continue with its rapid action, and the degludec actually works as a long basal acting insulin. Okay? And hence you see the profile of co-formulated insulin IDegAsp that it doesn't have the so-called shoulder effect, and hence less risk of late postprandial hyperglycemia, and so that is one of the advantages of the co-formulated insulin, low risk of hypoglycemia. Okay. So this, I'm sure you are familiar in terms of the journey of a patient from diagnosis of diabetes all the way to the fact that they require basal bolus injection. Okay? And the problem, studies have shown that if a patient is on a basal bolus injection, then the adherent to treatment is only 19%. Okay? So this explains why many patients do not achieve target, because part of the aspect of adherence to insulin schedule. Okay? So coming back to the ARISE study. Okay, what ARISE study is looking at the use of insulin IDegAsp in the real world study. Okay? What do you mean by real world study? Real world study means basically most drugs require a randomized controlled trial for it to use its efficacy and safety and required by the regulatory authorities. But the issues with randomized controlled trial is that they are very selected to make sure that the patients are very homogeneous to minimize the variations that you can get. Okay? And studies have shown that if you look at the inclusion-exclusion criteria of a randomized controlled trial and compared to the patients that you and I see in the clinic, only 20% of the patients of your clinic can fit into the randomized controlled trial criteria. And we are using this for other patients as well. The real-world evidence comes from using this therapy in patients that you and I see in the clinic, meaning the other 80% of the patients not included in the randomized controlled trial. Okay? So in terms of the rationale is that this non-interventional study, which is a study where patients done in 6 countries, Australia, India, Malaysia, Philippines, Saudi Arabia, and South Africa, where patients who are seen in the clinic and taught by the treating physicians that I'll probably put them on, I can start them on IDegAsp because they're not well controlled. Okay? And this primary objective to effectiveness of IDegAsp in real-world population, basically the clinic population of patients who were initiated or switched to IDegAsp from previous anti-hypoglycemic treatment according to local clinical practice. Okay? And you see the key inclusion criteria is that essentially any adult patient who have diagnosed to have type 2 diabetes mellitus and they're not well controlled on their present treatment. Okay? And for that reason, the physician thought that, okay, I'll start them on IDegAsp, and the patients will follow up for a period of about 6 months to 9 months, okay, to see what happened to them. Okay? So these are the subjects who were included in the study: 1,400, 1,462, 1,122 signed informed consent, 1,102 initiated with IDegAsp, and 1,015 completed the study, yeah? Giving a completion rate of 92.1%, yeah? Which is very remarkable, considering that when we did the study, it was the start of the pandemic, 2020. So patients were still able to come to complete the study. Okay? So these are the baseline characteristics of the patients in the study. As you can see, from the mean age, 58.6, to the mean A1C of 9.8%, male and female around about 50-50, fasting plus 11, and duration of diabetes 13 years, and BMI of 29, which are probably the typical sort of patients that you and I see in the clinic. Okay? Not responding to treatment, what to do with these patients. Okay? So these are the treatment that the patient was on before they were added or insulin switched to IDegAsp. OAD only 35%, basal only 21%, GLP-1 receptor agonist 8.2%, basal bolus insulin 13%, and premix insulin 21%. So you can see a wide variety of patients on different treatments. Okay? And when patients were prescribed IDegAsp by the physicians, the once daily was 52.2%. Possibly people who failed OAD, people on basal, and they were started on once daily. Twice daily was 47.6%. These are possibly patients who are already on premixed insulin twice a day, switch dose for twice a day of IDegAsp. Okay? And interestingly, 0.2%, 2 patients were put on other. Okay? And from what we gather is that these 2, the physician actually forgot to tick whether it once or twice a day. So they were the 2 put and others. So, but nevertheless, 2 does not affect the analysis. Okay? This was the starting dose of IDegAsp, total daily dose of IDegAsp for these patients. Okay? Overall, it's 36%. Okay? OAD was 22 units, okay? Basal only 37 units. So in general, certainly less than 50 units per day of IDegAsp. Okay? This is the change from baseline. Okay? That overall there was a 1.4% reduction in A1C. Okay? And the best is seen in the OAD alone, 2%. Okay? Even in patients who are on basal bolus, also reduction of 0.9% significant, and patients who were on premixed insulin, 0.9%. Even in patients who were on GLP-1 receptor agonist as well, a reduction of 1.3% A1C. And then looking at the country profile, the best is generally seen in Saudi Arabia, 2% reduction. And this is because they had a higher baseline A1C. Normally, if any treatment, the higher the A1C, the better will be the A1C reduction. But generally, for all countries, it seems to be consistent in terms of A1C reduction. Okay? Fasting plasma glucose also shows a similar trend. 2.7 millimole reduction in fasting plasma glucose, okay? And the highest best is seen in Saudi, again because of the highest fasting plasma glucose at baseline. Okay? By treatment group, okay? This is in terms of weight. Okay? This is very interesting because you see weight reduction in people even if they were on previous insulin, basal bolus, okay? And premix, and even people who are on OAD alone. Because you generally think that if you start a patient on insulin, they tend to put on weight. Okay? Why do they lose weight? Okay? The reason being because IDegAsp, the degludec, is more liver specific, does not affect the adipose tissue so much. That's why you don't get weight gain. Okay? A change in total basal and prandial daily insulin. Okay? The total dose of insulin, 0.6. So, okay, and the basal insulin was down by 2.3 units, significant reduction for basal unit, and the prandial insulin goes up by about 1.8 units. Okay? So generally, despite a lower total daily dose of insulin, you still get better A1C and fasting glucose reduction. Okay? All right, so about non-severe hypoglycemic stage. Okay? So this is before they were started on IDegAsp, and while they were on IDegAsp, before the end of study, there was also reduction as far as non-severe hypoglycemic events. Okay? Suggesting that, so if you get a surprise, you would expect that with better A1C and better glucose control, higher risk of hypoglycemia, but you don't see that. Okay? And also for severe hypoglycemic events as well, this is prior to treatment, this is during treatment, again, a lower, much lower rates of severe hypoglycemia. So in summary for this study then, A1C was significant decrease in A1C, fasting blood glucose was significant decrease, as well as body weight. Okay? Insulin dose was lower daily basal, but higher prandial insulin dose, and there was also significant reductions in hypoglycemic events, and resource utilization, i.e. the time we also collect this data when the time that they see their doctors, the one that they need to be hospitalized was also lower, possibly because of the lower rate of hypoglycemia. Okay, so the use of IDeg in special populations. Okay, this is the pharmacokinetic of insulin degludec in patients with abdominal renal function, normal abdominal. You can see that it's within a very narrow range, so suggesting that it can be used in people with end-stage renal failure. Okay? But obviously, in people with end-stage renal failure, we have to be very careful with insulin because they have a high risk of hypoglycemia. So that have to be carefully monitored. Okay? And in elderly people as well, concerned about hypoglycemia, then of course, the advantage of that is that the dosing is flexible. So even there is patients miss meals, for instance, then they can adjust the dose of the timing of the injection. Okay? And in terms of the clinical guidance and initiation, because we know that superior reduction in A1C, lower risk of hypoglycemia, and more patients are likely to achieve target without hypoglycemia. And so it's recommended that we can use it as an initiation to OAD failure, combination of basal and prandial in one pen, and then patients who are already on basal insulin alone and who fail, then the study shows putting on them on IDegAsp, a combination of basal and prandial, gives rise to a better glucose control. So in summary then, use of co-formulated insulin from this study arise, and other studies should improve in total glycemic control, assurance of reduction in hypoglycemia, less hypoglycemia, and also being 2-in-1 that can simplify insulin therapy from 2 pens, basal and prandial pen, to just 1 pen. Okay. Thank you very much for your attention.
Thank you so much, sir, for your kind presentation. I request Professor Dr. Zafar Ali Chaudhary, Vice Chancellor, Faisalabad Medical University. Please, sir, take your seat on the stage, and you will give laptop to the lucky one. If you will be not the lucky one. अगर आप lucky one हुए तो फिर किसी और से हम request कर लेंगे. रिजवानुर रशीद साहब डायरेक्टिंग मार्केटिंग एंड सेल्स हैं. इसके लिए हमें स्पॉन्सर किया CCL, particularly the Gabel and CR group. Our next speaker is Nita Maheshwari. She is the head of medical affair at the Helix Pharma. He will deliver his talk on a very important topic of relief trial. Before this talk, we will go for the lucky draw. किसको लैपटॉप चाहिए? मैं जफर से रिक्वेस्ट करूंगा, जफर साहब प्लीज जरा लैपटॉप डिस्प्ले कर दें. लैपटॉप डिस्प्ले कर दें जल्दी से, हम थोड़ा सा टाइम है हमारे पास. किसको चाहिए? हाथ खड़ा कर दे. अब ज्यादा खड़े हो गए, हम लकी ड्रॉ ही होगा. तो लकी ड्रॉ के लिए मैं रिक्वेस्ट करूंगा प्रोफेसर डॉक्टर ज़ाहिर यासीन हाशमी, हु इज द फाउंडर ऑफ लिवर फाउंडेशन ट्रस्ट एंड आल्सो ही इज द CEO ऑफ द लिवर सेंटर फैसलाबाद. सर प्लीज अनाउंस अ लकी वन. This is sponsored by the CCLs, particularly their group Gabel and CR. Dr. Muhammad Irfan Rashid from Gojra and Toba Texing हैं तो मिलेगी, नहीं है तो हम इसको कैंसिल करके नया ले आएंगे. डॉक्टर इरफान रशीद आई थिंक वो नहीं है. He is the consultant gastroenterologist from the Toba Texing. दूसरे जी नेक्स्ट, अभी मौका है सबके लिए.
इश्तियाक अहमद फ्रॉम लाहौर.
इश्तियाक अहमद, डॉक्टर इश्तियाक अहमद फ्रॉम लाहौर. अगर है तो ठीक है, नहीं तो हम नेक्स्ट पे जाएंगे. नहीं है नेक्स्ट, नहीं है. कंपल्सरी है कि उसको हॉल में मौजूद होना चाहिए.
डॉक्टर मुबारक अली अंजुम.
डॉक्टर मुबारक अली अंजुम, असिस्टेंट प्रोफेसर ऑफ मेडिसिन, अजीज फातिमा हॉस्पिटल. डॉक्टर मुबारक अली अंजुम सर ने अपने ट्रेनिंग की निकाल दिया. Now I request Professor Dr. Zafar Ali Chaudhary, please give a laptop to our lucky one, Dr. Mubarak Ali Anjum. This is sponsored by the CCL Gabin CR. Chale, Mubarak Ali Anjum Sahab, most famous personality of the Faisalabad. He is the consultant physician, assistant professor of medicine, Aziz Fatma Medical and Dental College. Mubarak. Now I request Dr. Anita Maheshwari for his presentation on the relief trials. Hand mic de de, please, hand mic. Jaldi.
So, Assalamu alaikum everyone. I hope you all are hearing me. Yes or no? So yeah, a very, very warm welcome and greetings, and especially I would like to send best wishes to all the Hindu doctor here and all the colleagues who are celebrating the Diwali. Yes, it's a very, very privilege, high honor for us as a Helixian for getting this opportunity to present the most anticipated relief trial results over here, and it has been conducted under the umbrella of HERA. Now you would be wondering, what is this HERA? Is this girl or kind of any other thing? So HERA is basically Helix Initiative for Research and Academics, and under that umbrella, under that platform, we have conducted this research which is real world evidence. As we all know that Pakistan is having, lots of data lacking whenever we come to have real world evidence over several elements. So हमें बहुत ज़रूरत है, हम सब जानते हैं कि हमारे पास resources कम है, funding नहीं है, and there are so many challenges while conducting the researches. But yes, pharmaceutical are open, like Helix Pharma is supporting this initiative all across Pakistan, and we have published this data in UK journal, that is Drug in Context. It's a high impact factor journal and having a peer review international reputation. So yes, we begin the journey over here. When we talk about the diabetes prevalence, so globally we see that it's 35% to 60%. So any idea कि पाकिस्तान का कितना हो सकता है diabetes gastroparesis का prevalence? Any idea, any guess? हमने बात कर ली globally कि it is around 65%, 35% to 65%. So what is the statistics when we talk about the Pakistan data, or Pakistan this disease? How much? 20%, 30%, 40%, how much it is? Is 15% somebody is telling, 50% somebody is telling. So it is basically, our study has stated it is around 35%. And this study has been conducted on safety and efficacy of etopride in those patients suffering from diabetes gastroparesis. Diabetes gastroparesis की इतनी सारी यहाँ पर इस कॉन्फ्रेंस में बात हुई है, बार बार तस्करा हुआ है, कॉम्प्लिकेशन बहुत ज़्यादा होती हैं. And I really would like to highlight that एक बहुत important complication gastroparesis होती है जो diabetic patients suffer कर रहे होते हैं. Beside all micro and macro level, neuropathy, retinopathy, cerebrovascular, cardiac, उसके अलावा भी ये very major sort of complication which patients are being suffering. So here you see the prevalence, and I have already defined the objective, safety, efficacy. It is very imperative that conducting